Thanks for coming back from the lunch, actually, and thanks for the invitation. You may have noticed that the last year was quite a humble year for nephrologists because it took only one journal report in the New England Journal of Medicine to wipe out everything nephrologists were fighting and struggling for decades, namely telling that there is no benefit of sodium bicarbonate over still crystalloids, that there is no benefit of acetylcysteine over placebo, and taking into account perfect endpoints like kidney function at 90 days, MACE rate, and contrast-induced nephropathy. In fact, the trial was stopped early according to pre-specified endpoints and showed futility, but still was 10 times bigger than any trial attempted to that moment. So in the end, the nephrologists are left with something like this: little P-man, please take care of the kidney scenario. Okay, thank you. So to set the stage in the next minutes, I'm allowed to say that because my former life before becoming a cardiologist, I was in nephrology actually and took board meetings. I wanted to address three topics together with you. First, is there a need to address medical contrast-induced AKI? We'll have a look at the data of impeller-assisted PCI to procure kidney function, and then I would like to allude a little bit, because we saw the brilliant ideas of Jem Udelson, what could a PROTECT kidney trial look like? Well, of course, there is a burning need to address CI-AKI because we know that it is associated with mortality. It actually adds up to existing CKD mortality, as you can see on the right side. It ranks second among causes for acute kidney injury, this contrast application. And so, to make it more clear, you can see that, wow, if somebody with a reasonable GFR between 30 and 60 for us interventionalists experiences acute kidney injury, his mortality over the next year is the same like a close to dialysis patient you are performing interventions on. Nevertheless, it is better to perform this angiogram than not doing it. Glenn Scherto, one of the biggest guys in nephrologists we can have, actually coined the term renalism, because he says, wow, we definitely know that we save lives performing angiograms exactly in this population, but we don't do it. Okay, so just imagine for 1 second that you are a kidney, right? And now contrast comes on. What will happen next? First step will be you will see a decrease in your renal blood flow, and you will see a decrease in GFR over the next 48 hours. And the mechanism of action that may be involved are various. You have mesangial cell contraction, you have constriction of the efferent arteriole, you have medullary edema, and altogether they lead to a decline in GFR, and most likely a unifying concept is that oxygen goes down within the kidney. The mediators are numerous, and so obviously are the ideas to start to interfere with acute kidney injury. But also here, as a matter of fact, you can see whenever it's said, wow, it may be protective, the authors of this brilliant review said, well, it was obviously a low-quality study. When it comes to high quality, oh, we didn't see any effect, right? And so the authors conclude with this little P-man from Brussels, well, only volume loading for the prevention have proven to be of value. So when you want to address acute kidney injury, here just some clinical notes. I mean, we all measure creatinine, and we feel a little bit odd because we're measuring this for decades, right? But it's actually the standard measurement, also included in the KDIGO guidelines, but it's rather insensitive and delayed of action. You can see 1 day later what happened yesterday, so it is not perfect. There are numbers of biomarkers, especially if you want to go shopping with the industries, and they are exactly faster, like NGAL or anything, but they are rather non-specific. For NGAL, example, goes up when you have sepsis, so you cannot use it anymore. And of course, they're not as validated as the creatinine levels. There may be proteomic panels in the future. One easy to monitor thing is urine output. You may feel even more odd in terms of looking at urine instead of serum creatinine, but it is definitely outperforming actually creatinine values and all the other biomarkers. And what we usually did in Berlin in the transplant unit, which is also now picked up by the literature, is a so-called furosemide stress test. So if you have somebody you feel like, okay, could this guy run into kidney injury, you can administer 1 milligram furosemide in bolus and say, wow, if you react with more than 200 milliliters in the next 2 hours, then the chance that he will be on dialysis is very, very low. We used it usually with these guys coming back from the transplantation and asking, okay, will my kidney work? I'm really suspicious. And so you could do a stress test in this. So imaging techniques, we have gone to this in the previous talk. And there are a number of ones. The bedside one will be Doppler ultrasound, but I think, okay, you can definitely look at the anatomy. You can see maybe some kind of perfusion at the resistance index. If you are addicted to ultrasound, you definitely cannot tell anything about oxygenation. But it's rather incomplex. And I would like to focus on MRI, because bold MRI, we're doing this as a cardiologist frequently. Bold MRI can give you give you an idea of oxygenation within the medulla and also in the cortex. You can pick up various regions of interest, and you can really nail it down what is the oxygenation in that area. And with a one-stop approach, you can also measure the renal blood flow. These are data from healthy humans where you administer angiotensin II, and you can see really clearly decrease in renal blood flow picked up by MRI. So in terms of impeller, if we look again at these numerous factors, impeller may interfere with anything of those. I just made them blue. And so what is the idea that impeller may actually procure kidney function in our protected PCI world? I do not talk about CHOC because this is a totally different animal, right? So you all know the Flaherty paper, single center retrospective high-risk PCI in its classical fashion. So you had the inclusion criteria, anatomical, hard to intervene, and you had an EF below 35, and they were matching 115 versus 115 patients. And they just looked at, according to AKI criteria, was to the incidence of acute kidney injury. Well, the cohort was reasonably well balanced. They spent the same amount of contrast somehow, and this is the result. You can see that, wow, there's almost no creatinine increase in the guys receiving protected PCI on impeller. And this holds true for all terms of CI-AKI levels and also for the various cohorts of CKD levels. If you do multivariate analysis, then you can see, wow, impeller support is as important as reduced ejection fraction in terms of protection, so as normal ejection fraction in this area. And, well, of course, this was not easy to accept, right, that a device may protect against acute kidney injury. And actually, there was a letter in Circulation Research later asking, okay, isn't this only a matter of MCS devices? Should have IBP done the job? What about other PVADs? Of course, I mean, wow, 115 with 115 patients. This is a cool study, right? But nevertheless, this got published, and, well, we were, during the same time, we were curious about installing the ECMO on our cardiology ICU, and I said, okay, I want to have a clear-cut scenario, and why don't we just use ECMO for high-risk PCI whenever the company is around? And that's what we did. We did a single-center analysis of sequential elective high-risk PCI, determined by anatomical and clinical scenarios. We did not stick so much to the EF of 35%, because you all know, if you want guesses, use the ultrasound, right? So we had right heart catheters. If those were below 2.5, we said, okay, we can do it, or we should do it. And we basically decided whether to use an impeller or to use the ECMO platform on the availability that the ECMO team was around. Because, I mean, you can imagine that it was quite nervous to do an ECMO setup in this high-risk PCI scenario. So we checked as an endpoint incidence of acute kidney injury, about AKI criteria, and we checked for safety and visibility. Looking at the cohorts, they were similar to the other cohorts, although they had a little less contrast, a little more in the VA ECMO group. And we see the same picture as in the Flaherty paper, right? We see no increment at all in the creatinine levels periprocedural when these guys are protected by impeller. And we can see quite a bump up on those guys when they are on the VA ECMO during the intervention. We try to calculate the idea about the likelihood of acute kidney injury in this scenario by the Mayron score. Julian will allude to this further later. And actually the risk of getting acute kidney injury was pretty balanced in the two cohorts, and the observed kidney injury was like this. So it always goes down around this 10-12% when you have an impeller in, despite you have a high risk of acute kidney injury. Well, this is just for safety. The lesion is treated. We had no real problems in terms of peripheral ischemia. We had 1 blood transfusion in the Impeller group and some more in the VA-ECMO group. Of course, we were faster with the Impeller device, right? So does VA-ECMO, I would answer, doesn't offer any nephroprotection. And, well, one could ask as a next step whether reduced LV function is really a prerequisite for nephroprotection in this cohort. No, Julian will tell you in 10 minutes about this cohort, but I can tell you it works. And so, in terms of limitation and perspectives, I would like to conclude that Impeller support in the setting of elective PCI protects from contrast-induced acute kidney injury. It does so in the classic protected PCI setup, as done in the Polarity paper. It does so in the head-to-head comparison with VA-ECMO, and also does in propensity score matching, as Julian Viora will tell you in a few minutes. Of course, after having heard this beautiful keynote lecture, you will say, okay, this is also low quality, right? It is low quality. All conclusions are grounded on retrospective single-center analysis. We have no clue of the mechanisms involved. So I would like to share at least some data on a potential, just some glimpse on the protective kidney trial, what we could do in this cohort. We could use as an inclusion criterion a Mayran score of above 25% for acute kidney injury, because I've shown you on the initial slide that people encountering acute kidney injury are really at high risk of dying over the next year. So I think ethical, it is okay to do so. And then you could flip a coin because you don't have any data and say, well, one guy we do on Impeller, the next guy we do as we usually do. And this trial could also give us some insight about the mechanism. One mechanism may be that unloading simply facilitates adequate volume challenge in these guys. You may remember the Poseidon trial where you, according to the LVEDP, can give tons of volume in order to prevent acute kidney injury, or not so much. And when you do Impeller-assisted PCI, well, nobody with an Impeller in place gets short of breath on your PCI table, right? This will never happen. Impeller augments kidney perfusion. Well, we could check this by means of MRI, pre and post. We could address these unifying pathways like viscosity of the contrast. We could check vasopressin angiotensin too. My wife, actually, she's an endocrinologist, and all the time I tell her, well, you know, we infuse 1 liter of crystalloids, sodium chloride, in order to prevent contrast nephropathy, and this is protection. She says, no, this is a salt loading test. What do you measure? Nothing. We measure creatinine. We could do a symbiosis of endocrinology here in this setting and cardiology. And what we also could do is, because nephrologists somehow believe that one key player may be aggravated hypoxia of the medulla, we could go into the idea that we also change with bold MRI, measuring oxygenation in the medulla compared to the cortex in these guys pre and post intra-individually by bold MRI without the need of contrast. So lucky we are in Dusseldorf, we have, as you can see here, we have a cath lab which is directly close to our own MRI scanner. So we don't have to ask any nephrologist whether we can stick in the MRI once more or 2 times a day or 5 times a day. And it's virtually 10 meters apart. So we can, and we have a trolley system that a patient from the cath lab can go into the MRI scanner. And I would be really glad to do this kind of a trial. And yeah, these are the first pictures we have. It looks beautiful. I hope you can follow me with that, and I would really love to kickstart this trial together with Abiomed, and I would like to thank Abiomed in person, Jerry and Norm, to bring all this AQ faculty together now for the 3rd year. Thank you.
Well, very nice presentation. Of course, I'm a little bit disappointed by your one answer. We have no clue about the mechanism. What's your speculation?
Okay. Yeah, I adapted the slide after the keynote lecture because before I had an idea, but I didn't dare to leave it there. I mean, the actual idea I would have is that, you know, when you're a nephrologist and you put a transplant kidney in, the first thing you do is you measure with ultrasound the resistance index and the diastolic perfusion of a graft. Whenever diastolic perfusion shuts down, you say, oh, something is wrong. Then you may have swelling of the organ, but it definitely indicates that the kidney is not working. So my gut feeling is when you put an impeller in, you will not augment systolic perfusion, because in systole, especially in protected PCI, you will still have the normal heart doing systole. When you have the impeller in place, you will greatly affect diastolic perfusion. And by this, you will augment renal blood flow, and you will augment GFR, and you will augment getting rid of the bad contrast over time when the impeller is in place. And I would not expect autoregulation in terms of vasoconstriction, because the highest amount of adaptation to flow is the myogenic response of the renal, of the kidney, and therefore this will be adapt to higher systolic pressures, like in the ECMO setup.
Mm-hmm.
But if it is a perfusion, a blood pressure mechanism, why is then your ECMO not doing that? Because it is also increased.
Right. I mean, this is also only a hypothesis, so it's less than level C, right? It is. ECMO augments flow and also pressures systolic and diastolic. There are some data indicating that if you increase pressure, you have a very, very tight autoregulation of perfusion of renal blood flow by the kidney itself. And my idea is that if you add perfusion pressures in systole, the kidney will simply constrict his afferent arteriole, and you will rather diminish this idea. And there are actually data telling that this myogenic response, which is about 60% of the amount the kidney can constrict, this is more potent and more aggressive when you have higher O2 levels. And when you do peripheral cannulation of the ECMO, well, you run at 100% oxygenation there, and you have a strong myogenic response.
Question about the relative hypotension that can occur with PCI. Do you have any evidence that repeated or more numbers of inflations with significant drop in pressure is a bigger risk to the kidney than patients who don't get any hemodynamic change with PCI?
Wow. Yeah, Julian, have you heard this? Right? I mean, we have to look into this. We don't have data on this 12 patient. Of course, we have altogether about 100-something protected PCI guys, and we could definitely look into the sheets from Abiomed. I mean, you know this better than I do, that they have every information you could think of, and you can just ask them, and they will give it to you. So we will definitely do this. Thank you.
Free hemoglobin seems to be an important molecule interacting with renal blood flow. And as we see some cases of hemolysis from time to time, there is some mystery still to solve. What's your opinion about impeller-triggered hemolysis and kidney?
Well, we are also strong believers, for various reasons, that free hemoglobin may be a bad guy. And so there was actually a poster by one of our group, Jean-Marc. We looked at acute kidney injury and outcome data in shock patients, according to free hemoglobin, according to hemolysis, and we didn't see a sign. So I would say that these hemolysis that may take place during protected PCI doesn't matter.
Just one question.
Last question, yes.
Maybe one more sentence, just to, if you, for example, look into this autoregulation of the kidney perfusion, the latest and most advanced review article, there is no clear-cut statement in the end whether free hemoglobin augments or reduces kidney perfusion. We simply don't know, because there are some experiments going in one side, the other go into the different directions, so in the end it depends on so many factors, we simply don't know. And I would say, well, in protected PCI, it doesn't matter.
Do you think between the impeller and ECMO and the interaction of the heart and the continuous flow pumps, you have various degrees of pulsatility? Do you have comparison in your both impeller and ECMO cohort? Because we're learning from the continuous flow VAD world that pulsatility and lack of pulsatility could make a difference. And would you factor those in, and do you have data in your comparison how pulsatile in one cohort was versus the other?
Yeah, I don't have measurements on the pulsatility. All patients that we included in the trial for protected PCI or protect kidney PCI were were pulsatile on the device, we usually apply the impeller 2.5. So we didn't do any full or at least partial support. We only supported a little bit, right? They were just in the backstage. And what I can tell you from the interventions themselves, usually when you're doing protected PCI on impeller, you feel safe and nothing really could happen. Even if you mess up, like dissect the vessel, the patient in most of the time doesn't notice it. When you start the ECMO running in somebody with a cardiac output of, let's say, cardiac index of 2.0, and you just leave it running at a 2 liters per minute, which is the minimum of the cardio help, then it's getting really complicated. Because usually what happens is that the pressure drops, despite that you are doing some things in there. You ask yourself, okay, what kind of catecholamine should I use now? Shall I use an inotrope? Shall I use a vasopressor? There are no data around. And usually when we did these 11 ECMO cases, my coat was really sweaty afterwards. This usually not happens when you go to protected PCI with the impeller device. So there is definitely interference and a totally different hemodynamics on ECMO compared to impeller.